Good morning. My name is Dr. Reza Naghavi. I've been asked to give a small, brief talk as an overview of HIV AIDS as part of the discussion series that we're having on communicable diseases and opportunistic infections. HIV AIDS originated from what we believe from some species of African monkeys or simian monkeys or different species of monkeys in Africa. I believe that it's been around for probably millions of years. It's not just been popping up yesterday, but I think we have been able to locate the earliest documented infections going back to the 19th century. The disease is again an opportunistic infection, an opportunistic exposure, and basically is a debilitating disease that starts to eat our immune system from within once it's able to go through the transmission mode, which we'll go through briefly. It has been recognized that it has different subtypes, subtype HIV1, HIV2, or HTLV1 and HTLV2. And we have been able to sort of segregate and say which ones are more common and prevalent in the Americas and which ones are more prevalent in South Africa and Saharians and so on and so forth. It was brought to the public knowledge mostly in the AIDS crisis, HIV crisis in the United States back in the late 70s and early 80s, when we saw a very large insurgence of this particular virus that was able to cause a lot of deaths and a lot of infections that we had just been awakened to. I'm sure that for a long time this was going on in some areas of Africa, but it wasn't really being recognized and in the news, and may have been just written off as some other types of infections or weaknesses that people had. The virus itself is a single-stranded virus called a RNA kind of and it helps itself by being able to get into an opportunistic situation where it penetrates into the cell and starts to replicate within the cell. And it starts to become a part of our chromosomes and sort of embedded in our defenses. And as our cells are leaving markers that have been infected, our body tries to get rid of these cells, infected cells, and therefore our immunity and our immune numbers start to drop sharply. The relationship of its virulence and how effectively it is killing us and destroying us seems to be directly related to its effectiveness in lowering our defenses, our CD4 count and CD8 count, and so on and so forth. It also has a very close relationship with other opportunistic infections. Mostly people with HIV end up dying from other infections, secondary infections, whether these are Kaposi's, these are pneumonias, these are certain types of cancers that are virally related, and these are part of infections that sort of disable us systematically, whether it's Ebola virus, they could coexist, or the tuberculosis virus seems to be the most prevalent coexistence of the patients, and at least about a third to a quarter of patients who die from HIV are those who have latent tuberculosis. The other infections that we need to sort of worry about or are the ones that as the latency period for developing HIV symptoms and going from human immune deficiency virus to an AIDS virus, where our bodies become an autoimmune deficient subject, could be as high as 10 years. And we were just talking to someone in the audience that said that somebody had this virus for probably 15 or 12 years, 15 or 20 years before they actually came there to their demise. In the initial stages, it used to be 100% of a killer. We didn't have any defenses. We didn't know how to defend against this virus. But fortunately, with the further development of virus antibodies or antibiotics, if you will, or antiviral medications, we tried to figure out at what extent and at what positions of the viruses that were replicating could be put in a log and sort of interfere with its growth cycle. And that's how we came to the antiretrovirus treatments that have now sort of been able to quote unquote cure, if not keep people alive, as long as they don't have a secondary coexisting infections for a very long time. And almost a normal lifespan if they don't have secondary infections that will come to their demise. The presentation of the virus could be very much similar to tuberculosis or other infections. It could be fever, weight loss, lymph node swelling, particular skin rashes, particular indigestions or dysenteries or diarrheas, and so on and so forth. The goal of our diagnostic success is basically to try to figure out if somebody has been exposed to an HIV type of virus. And the only thing that we can really do is use a blood test. And these blood tests are 99% effective in diagnosing exposure. They also have a slight bit of false positive subgroup that are picked up as positive, HIV positive, but then once a two-step test is done, we will further eliminate those that are falsely positive. The way the transmission of HIV virus, from what we saw in mass, could have been through sharing of the needles. It could have been through blood transfusions that we didn't know we had to sort of scrub the bloods for detecting HIV, as we scrub the bloods for hepatitis and other disorders that we know are communicable. We didn't know that we should have been scrubbing. The other thing that really led to the number of HIV cases in the United States was, first it was thought that it was a homosexuality sort of a transmission through unprotected sex, but it was later learned that no, it was not just the sex. It had to have an entry point that sort of was able to penetrate within the blood system. So you could have sex and your chances of getting an HIV virus from somebody who's HIV positive, depending on the number of viruses they have in our body, is about 10%. But if you happen to add a sore or a break in the skin or the mucous membrane, then that chance goes up significantly and could be as much as 90 or 100%. So you really need a receptive a receptive host in order to transmit the virus. One of the things that we also saw is in the early 1900s, there was reusable needles that many practitioners used, both in the United States and worldwide, before we came into disposable needles. So we could have actually been inoculating and taking one infection to another, and seeding them. And then, depending on what the situation and the body's defenses were, these could have been sitting there for decades. We never knew how to recognize them. We didn't have an outbreak until the outbreak came in that particular group. And then now we realize it can spread quite a bit through other resources as well. A lot of the infection we realized was disseminated by using these infected needles in third world countries. Sahara, Sub-Sahara Africa, Far Asia, parts of South America. Again, because of the socioeconomical issues, they reused needles, they inoculated people and vaccinated people for measles, mumps, and rubella, and chickenpox and everything else, but at the same time, we gave them a virus too. That was a present we didn't know was giving. So that was a large transmission source for us in general. Today, basically, the battle is to try to keep the HIV virus or the viral load to less than 50 per millimeter per a quantity of blood. How many duplicates or replicates of a virus exist within a small amount is what we say this patient is now undetected HIV numbers, and they cannot transmit it if they're undetected, so we hope. And that's basically our goal, is to use these retrovirus treatments that we have to try to keep that number to the minimal undetectable levels. Very much similar to hepatitis C that we're now curing by being able to get them to an undetectable level that, again, will keep them at bay. As far as a vaccine does not exist in the United States or in the world for treating HIV. As our colleagues told us, we also don't have a vaccine for Ebola. We also don't really have a vaccine that works for tuberculosis or other opportunistic infection. Even the vaccines that we use for measles, mumps, and rubella, they also don't have 100% certainty of protection. They provide a certain percentage of protection which wears off after a certain time. So our entire protection of not getting it or spreading a disease is really on education. Making sure that people recognize the signs and symptoms of coexisting infections, whether it's tuberculosis or it's measles or whatever is going to suppress your immunity. Cancer patients are at increased risk as well. Kaposi sarcoma, which is sort of a known entity that goes with immune suppressed patients, could also be associated with the presence of this viruses. Today, we are now promoting using for people who are high risk groups, particular retrovirus regimens that the physicians can prescribe in order for the patients to reduce the likelihood of getting infected with HIV. Protected sex, not sharing of the needles, making sure there's no other coexisting infection like tuberculosis, making sure that somehow we make it a mandatory way to recognize through a blood test whether our patients have been exposed to HIV and whether they carry the virus, they carry the antibody, and whether or not the viral load exists. Just the screening test, I think, has been able to afford me at least a handful of people in the past 20 years or 25 years of my practice that we picked up HIV infections in them that would normally not have been picked up just by routine doing it. So it sooner or later we'll have to try to recognize that certain amount of expenditure and investigation, whether it's the TB gold quantiferon, whether it's the measles rubella titers, whether it's your HIV viral load or HIV antibodies, that will help us become better and better in controlling these outbreaks. Thank you.